to be involved a couple of weeks back with Dr. Murray. We don't get much peripheral nerve exposure per se, but it comes up pretty frequently on our board. So I thought I'd give a little talk on management of brachial plexus injuries. Several of the photos and some of the slides content in this presentation is from Dr. Murray as well. So thanks to him for looking over this. This is an unfortunate 46-year-old right-handed female who was cycling and lost control and fell approximately 4 months prior to she was seen in clinic by us. And she had impact onto her right shoulder. Initially, following the accident, she didn't notice any function in her right upper extremity completely. And subsequently, she noted return of function in the right wrist and hand, however, minimal function proximally, particularly at the elbow and shoulder joint. And so she was first evaluated in clinic in late October in orthopedic surgery clinic. Her past medical history was really only relevant for a couple of C-sections, a lap chole, hysterectomy. She was obese with a history of hyperlipidemia and hypertension, and a family history of Parkinson's as well. Occupationally, she was a software engineer, and from what it seemed like, a fair amount of her occupation involved sitting at a desk. On examination in clinic, she was 0 out of 5 to that right deltoid and 0 out of 5 to supraspinatus and infraspinatus, with some flicker of activation to the biceps rated at 1 out of 5, and a weak triceps, as well as wrist extensors and digital extensors, but the remainder of her distal right upper extremity, as you can see here by this exam, was strong. She had reduced sensation to light touch as well as pinprick sensation in basically the C5, C6 dermatomal distributions, and no biceps reflex.
Before, maybe go back one slide. So I would suggest you to maybe get one of our, team members and to ask a few questions in this type of area, like the neurological examination. The clinical history, as you know, at this time is really the most important part of the examination. So I wonder, you can select someone, but looking at this and this history and the clinical examination, where do we think the injury is located? And this amount of information should be enough for that.
Yeah, then any of the research fellows want to volunteer. Otherwise, unfortunately, I'll have to pick on somebody randomly. Maybe.
Don't say unfortunately.
Maybe. Diogo, do you have an idea of where you would localize this? So when we say localize, first of all, upper motor neuron versus lower motor neuron, and then where along the lower motor neuron tract is this distal or proximal?
Sure. I mean, from my understanding, I would say lower motor neuron, and then deltoid and supraspinatus. If I'm not wrong, that's like C5, 6. So deltoid is axillary nerve. So I would say, this would be something like in the brachial plexus and probably not in the, most proximal. I would say most distal, given that some other muscle groups are not affected.
Yep, for sure. Very nice. So yeah, definitely, as you said, deltoid is a C5. She's got evidence of C5, C6 root involvement by the weak deltoid in the biceps. Hard to say necessarily if it's, you could localize it to the axillary nerve. Given this exam, I would say more upper trunk, something to consider. And we can see how our EMG looks.
Consider, right? It's kind of like the neurological examination, the clinical history that you shared. It's pretty classic of upper trunk, right? And this once again, the neurological examination will be the really one to determine this. So the combination of the deltoid, the biceps injury, the history of injury, and the combination of motor weakness in the deltoid and the supraspinatus and the sensory changes, they're very, very classic. This is a very classic history of superior trunk.
Okay.
Exactly as JP said. So this is her EMG, her first EMG, and fortunately we spent 2 months with Dr. Rubin in clinical neurophysiology as PGY2s going over EMG, so we get a little bit of familiarity with EMG. But basically, the top is a nerve conduction study, so they're recording both motor and sensory action potentials, proximal and distal, and then the main things we look for are the amplitude, which is this. I don't know if you can see my cursor, but this column, and then the conduction velocity and the distal latency. So, for instance, one of the classic findings in carpal tunnel syndrome is prolongation of the distal latency in the median sensory. That's some of the earliest findings you see. And then you also want to look at the motor findings. If, for instance, we're looking at carpal tunnel. So in this case, they checked radial, ulnar, and median, and they checked some cutaneous nerves here. The second part of the EMG is the actual needle exam, where they stick needles into the muscle and they record activity. And so when they do this, they're recording a few things, or they're looking at a few things. The first thing is called insertional activity, which you see here, and this is rated as basically normal or increase. And the second thing they look at is for any spontaneous activity. So these are classified into either fibrillations or fasciculations. And these are just rated qualitatively as 1+, 2+, 3+, 4+. And then finally, they measure the actual motor unit potential. And so that's what you see here. And most notably, what you see here is oops, I went to the wrong side, my mistake. You see marked increased insertional activity with the presence of fibrillations at the biceps and the deltoid, as well as in the brachioradialis. And you see poor activity in the brachioradialis and no activity in the biceps and deltoid. Interestingly, the C5 paraspinal was normal, suggesting there may be some function at the C5 nerve root level. They didn't test C6 in this study, unfortunately. This is just a diagram just to recapitulate some of the things we go over ad nauseum in medical school and in residency about the brachial plexus. But basically, this is just to show the course, so you can see the C5 and C. Like Diogo had said, we're localizing this to the upper trunk, so we can see the course of the C5 and C6 nerve roots here as they unify to become the upper trunk. And here we can, on the left diagram, you can see the relationship of the trunks and roots supraclavicularly, and then you can see the relationship of the cords and the terminal nerves infraclavicularly, which will be coming in later slides to be important for the exposure. And so the decision at that point, so this was in late October, the decision at that point was to give the patient 6 to 8 weeks and see how she goes and repeat an EMG. She was seen again in clinic in mid-December, and unfortunately she had minimal improvement in her elbow flexion and shoulder abduction. Her repeat EMG, as you can see at the bottom, unfortunately also didn't show any evidence of reinnervation. So one of the first things you see on EMG and reinnervation is the presence of very large amplitude motor unit potentials, and this is just early reinnervation occurring at the distal motor end plate. And so as you can see here, she had substantial fibrillations. Now she's got 3+ fibrillations on this EMG in the biceps as well, where she didn't have that previously 6 weeks ago. And she has no motor unit activity there and increased insertional activity. And so, like we had said previously, this seems to localize to the upper trunk affecting C5, C6. At this point, the decision was made to obtain a CT myelogram, and this was to determine if the injury was preganglionic, that is to say, involved nerve root avulsions of C5-6, or it was postganglionic. This would have implications, as you'll see later on. I'll go into more detail regarding the possible surgical interventions to consider, including nerve grafting versus nerve transferring. As Dr. Murray tells us, CT myelogram is kind of the gold standard. It is an invasive test. They do have to inject contrast intrathecally, unlike a MR, but it provides high detail regarding the nerve roots. What you see here on the coronal on the left, so this is my cursor is pointing to the C5-6 level. You can see the exiting roots there at the levels above. And what you see here on the right side at C5-6 is that there's no exiting root, which suggests avulsion of the right C6 root. And this is again demonstrated on the axial that you see here. So here you can see basically an empty nerve root sleeve. And on the left side, you can see the presence of the dorsal root and the ventral root that going there. So that's C5-6. Here, this is just one slice inferiorly to demonstrate what appears to be a small dilatation of the sleeve and possibly a small pseudomeningocele at that level entering the foramen. And on the right side, you see the level above showing the C5 root. And you can see the presence of a dorsal root, but it looks like there's been an avulsion of the ventral root. It's kind of hard to make out. On the left side, you can see a more clear ventral root, but you don't see one on that right side there. And so, given this CT myelogram showing imaging evidence of preganglionic injury, we had a few management options. Really, in terms of surgery, observation for her really wasn't an option given the fact that this imaging did show nerve root avulsions. And so this patient would basically have no chance of recovery without considering surgical intervention. in terms of the intervention options we considered, nerve grafting versus nerve transfer was discussed. The goals of this intervention would be to try and restore shoulder abduction with deltoid and elbow flexion with biceps, as well as some rotator cuff function. This patient would be likely a poor candidate for graft procedures, like I said, given the presence of a preganglionic injury. And so the decision was made to undergo nerve transfer procedures. And so the goal of this was to basically do three procedures. One was to do a transfer from the spinal accessory nerve to the suprascapular nerve. Secondly was to do basically an Oberlin transfer. And thirdly was to do a axillary radial transfer. So I'll go into more detail on the next slides. I don't know if Dr. Murray's online, if you had any comments at all. He said he was in pre-op. Might still be in pre-op. At any rate, this is not.
Yes, Krishnan. Sorry. Hey, Krishna, for the, so what, this is a question. When you saw the deficit early on, let's say you saw it in the emergency room, why did you repair it then?
The reason for not repairing it then was because it was likely suspected to be a blunt injury. If this were a penetrating injury, then or pure transection like an iatrogenic injury, then we would repair it then.
Correct, yeah, because if it's a blunt injury, obviously the nerve, you want to see that the nerve recovers on its own, and that's why you give it time. And that's why you did the serial nerve conduction test. If you go to the operator and try to repair it, you'll permanently damage some of those nerves.
Yes, sir.
But obviously, like you said, with the transection injury, that would be a direct repair. It would be an indication for an emergent procedure in that case.
Yep. Yes, sir. I've got a couple slides on that at the end of the presentation as well. So the setup, so the head was turned to the left side, and we planned a transverse incision, kind of like an ACDF, 2 fingers breadth above the clavicle. This is pretty much the setup we used, and in this case, the right arm was prepped, so we didn't have the 1010s there, and we planned for a posterior incision for access to the to get to the axillary radial transfer completed, as well as the medial aspect of the right upper extremity to do the Oberlin transfer. What we used here is depicted in this image. In other textbooks and more neurosurgical literature, you see kind of a carotid type incision where they go along the posterior border of SCM. And so that's some of the images you may see in like the Dr. David Klein textbook, The Atlas of Peripheral Neurosurgery. So this is some intra-op images on the right from the supraclavicular to, from the, accessory to suprascapular transfer, showing the supraclavicular brachial plexus exposure. The left is a diagram from Dr. Klein's textbook outlining just the operative anatomy. And so just to orient it, so this is the posterior border of sternocleidomastoid. The clavicle is down here on the left side of the image. And then this is the omohyoid right here. This nerve that they reflected is likely the great auricular nerve. And you can also see here the presence of the supraclavicular fat pad. And so the dissection for this is, similar to any anterior cervical approach, either the carotid or the ACDF, but it essentially involves getting through the platysma, a subplatysmal dissection, identifying the posterior border of the sternocleidomastoid, the omohyoid, and then deep to this is seen the fat pad as well as the anterior scalene, not reflected in this diagram here. The other important thing to consider is that the spinal accessory nerve is, of course, small, as we know, from its exit from the skull base down across the mastoid. And so it can be confused for other branches, namely the transverse cervical nerve branches sometimes, but these are typically running, just like you see in ACDF exposures, more parallel in the direction towards the clavicle medially. The right side just shows the exposed spinal accessory nerve, as you can see here, and the suprascapular nerve here. So in this case, the transfer has been completed. And this is just to show how this would look once everything is exposed. In her case, she didn't have a pristine omohyoid. The omohyoid was pretty much almost completely retracted. And what we found intraoperatively was indeed the presence of a C6 avulsion. So we confirmed this using intraoperative neurostimulation. We did note that there was some function of C5. What you see here is the process by which the nerve transfer is complete. And so you see the background here, and you can see that the spinal accessory nerve has been freed up from its exit point on the posterior cervical triangle, and the nerve transfer complete. Dr. Murray does his nerve transfers with 2 tenos sutures, so he tags the epineurium of the donor and recipient, and then he uses fiber and glue to seal to complete the transfer. There's various ways to do this. If we look at the literature, some people do more sutures, some people don't even use sutures at all, and only use fiber and glue in some of the neurosurgical papers I saw. But the idea is to minimize the amount of suture holes, if possible, to minimize granulomas from forming at the suture lines.
Yeah, I think one point to make there too, Christian, is that fiber and glue has never been shown to add any measurable strength to the repair. It's an approximation substance, so I think it's a little bit risky to kind of rely on it for your coaptation alone.
Noted, sir. Thank you. This is to show the anatomy of the posterior incision that was done for the partial radial to axillary transfer. And for me in particular, this is anatomy and an exposure that we get minimal experience with, and obviously the orthopedic surgeons are intimately familiar with this anatomy. But just to orient, so this is the posterior aspect of the arm, and you can see here this diagram from Dr. Klein's textbook pointing to the long head of the triceps, and here you see the radial nerve isolated with the vessel loop. On this right side, retracted inferiorly, you see the lateral aspect of the triceps in this intraoperative photograph. And so this picture on the left identifies the 2 spaces, the quadrangular quadrilateral space and the triangular space, to identify both the axillary and the radial nerve respectively. And so the muscles to identify, importantly, would be the teres minor running superiorly, the teres major, which is kind of running behind you, and I think they've reflected the head of the humerus, the shaft of the humerus right here, and then you can see the long head of the triceps right here. The incision ends up being a long posterior incision along pretty much the entire posterior aspect of the arm, and this allows for identification of the radial nerve more distally as well, and like I said, more mobilization. Dr. Murray, did you have any other comments at all?
No, just that we have several choices. We typically just take the most robust branch, which is usually the branch to the long head of the triceps. And we identify that using handheld nerve stimulator. And then we have the option of coapting to the entirety of the axillary nerve, but typically only take the anterior branch of the axillary nerve, where the long head branch, usually from a fascicular anatomy perspective, satisfies those the fascicular anatomy of the axillary anterior branch.
Thank you, sir. And then this shows the anatomy, the intraop anatomy identified for the Oberlin procedure, the partial ulnar to biceps branch of musculocutaneous. On the left is another diagram from the Dr. Klein atlas showing some of the anatomy of to show the median nerve. In this case, I've also identified the brachial artery as well as the ulnar nerve. So this is the medial epicondyle, and you can see the ulnar nerve running in the cubital tunnel. Here, like I said, you see the median nerve, and then you identify the triceps brachii as inserts there. And so proximal ends up being to the left of the screen. The incision for this is on the medial aspect of the arm, and so that's what we did, and it was kind of curved slightly medial to enter the axilla proximally. On the right panels, you see the identified biceps and brachialis branches of the musculocutaneous nerve. So the biceps one heading more medial and the brachialis one heading more lateral. And here you also note the lateral antebrachial cutaneous nerve heading into the forearm there. This shows the identified and isolated donor and recipients. So the biceps branch, the biceps branch right here that has been isolated. And then here you see some of the fascicles from the ulnar nerve, which are then used for coaptation with the background to complete the nerve transfer, as said. Excuse me. And this is the original procedure as described by Dr. Oberlin in his paper, I think from 1995 or 1996. Always comes up on our written boards about what this entails. So the patient The entire procedure to complete those 3 procedures took better part of, I think, 8 hours or so. We started first case and probably finished up at 4 p.m. or something like that, 5 p.m. But she did well. We placed a drain at the cervical incision, and the drain was removed uneventfully on post-op day 1, and the patient was able to discharge, in fact, on post-op day 1 with preserved trapezius strength. I wanted to go into just a brief overview of some of the management of brachial plexus injuries, just because, like I said, this comes up on our boards a lot. As Dr. Chachana was mentioning, the timing and type of injury and how you repair them always comes up. And so basically, the separation is really between penetrating versus blunt. This is a relatively recent, large systematic review and meta-analysis looking at the etiology and really the prevalence of severe injuries that required surgical intervention. And as you can see here from their table 2 detailing the prevalence, the overwhelming majority of these injuries are occurring in males, so 93%, and 93% of them are closed injuries, with only a handful of them being penetrating injuries, either via laceration or from gunshot wound. Also in this series, 2/3 in their entire cohort of included studies comprise injuries resulting from motorcycle accidents. And so, like we mentioned at the beginning, once the injury is identified, the other next step is to see if this involves a complete avulsion, that is to say a pre-ganglionic injury, like you see here is a ganglion, or a post-ganglionic injury, so an avulsion versus a rupture injury. And this has implications for the possible surgical interventions that could be considered. Typically, the injuries that we've seen with traction without complete nerve disruption result in rupture. However, in this patient, though this was a blunt injury, she unfortunately did have a C6 root avulsion. And so the timing of intervention is something that also always comes up on the boards. As Dr. Chachana mentioned, if it's penetrating, if it's a sharp injury or a transection, then the board answer is to repair immediately. And I think this came up on an oral board case I remember Kelly Gasser doing last year, where you cause an iatrogenic injury of a nerve root, what do you do? So the answer is you do an immediate repair then and there. This is a recent JNS paper that was published about a few years ago, and it looked at basically the degree of strength recovery using the standard motor scale, so 0, 1, 2, 3, 4, 5 on the MRC scale, and the percentage of patients that recovered at various time points. So 3 months, 0 to 3 months, 3 to 6 months, 6 to 9 months, 12 months, and beyond a year. And basically, the trend overwhelmingly is for earlier repair. And so 90% of patients could get anti-gravity, so greater than 3 out of 5 strength when operated on within the first 3 months, particularly in the upper trunk lesions, as you see here on figure 2 in the top right diagram. When patients are waited on for more than a year, then the success of an anti-gravity recovery substantially drops and is only about 1/3. So as you can see, based on the overall trend in this, there's significantly better outcomes seen for anti-gravity recovery when patients are operated on, in less than 6 months. Surgical indications for brachial plexus intervention include panplexus nerve root avulsions, any acute penetrating trauma to the plexus, and the presence of a repairable lesion, either something that could be targeted via intraplexal repair or nerve transfer, or an extraplexal nerve transfer. The techniques involved include either grafting or transfer, broadly speaking, and grafting or transfer can be performed intraplexally or extraplexally for transfer, and finally, more extreme techniques involve free muscle transfer for patients with essentially involvement of multiple roots or a complete panplexal injury. Indications for grafting are quite specific. They require the injury time to be less than 6 months, and most importantly, they require the presence of an intact proximal nerve. So it has to be a post-ganglionic injury. The deficit can't be that long, otherwise it can't be bridged, and it also requires the tissue bed to be healthy and there to be an available graft. For nerve transfer is basically not repairing the nerve directly itself. You're basically transferring, as the name implies, a function of a nerve from somewhere else to this non-function to reanimate this muscle. So in our case, we took accessory nerve to reanimate the muscles supplied by the suprascapular nerve in this case. The main indications are preganglionic injuries or nerve root avulsion, and when the defect is larger and distant from the motor end plate, as well as a prolonged post-injury time with multiple levels, as you saw in this patient. In this patient, she was pretty much on the dot at 6 months from injury when we did the procedure. Nerve transfer, like I said, so this is a just intra-op photo. I think this is just a zoomed in picture from the Oberlin transfer that was obtained from Dr. Murray. And basically, just the principles are somewhat similar to microvascular anastomosis in that you want the caliber of the donor and recipients to be of similar size, so one shouldn't be substantially oversized compared to another. There can't be too much tension. You need ample length on the donor nerve. And you need it to be pure motor as well, given that you're requiring or you're asking it to reanimate muscle. The other important thing is the donor nerve should have at least 4 out of 5 strength, which this patient did in her trapezius, if you remember, preoperatively. Some of the contraindications. The main contraindication is basically if the patient is already doing well with conservative management, then at that point, you continue to watch them. So as Dr. Chachana was saying at the beginning, in the case of a non-penetrating injury, if the patient continues to make meaningful recovery, then you continue to observe, as we did between the first and second clinic visits, to see if there would be further recovery and monitor the condition with serial EMG potentially. The other time you would hesitate to consider surgical management is when, like I said, based on the previous literature, if the injury has been more than a year out. The exceptions to this are pediatric cases and cases where you can do the coaptation very close to the end plate. So upper trunk brachial plexus injuries in particular, as JP was saying at the beginning, really a pretty substantial, significant disability. And so you lose your ability to abduct the shoulder, externally rotate, flex the elbow, and then supinate the forearm, as you can see here. And so the treatment priority is really to restore elbow function. This patient had intact hand function, but without the elbow, if you think about it, if your elbow is completely extended, even if your hand is functioning, you can't really do anything. You can't pick anything up if you can't use your elbow in space. This is a recent JNS paper just comparing, based on systematic review, various repair techniques, specifically for upper brachial plexus injuries. And they compare, in this paper, the study authors compared grafting versus transferring versus a combined procedure. And really what they showed is that there's no one specific technique for elbow flexion in particular that is more powerful. The overall trend kind of depends on the severity of the injury. The really gold standard for this, for repair, if possible, would be the nerve graft. But like I said, if certain conditions aren't met, then this is not possible. And so surgical techniques to repair the upper trunk for gaining elbow flexion, as we did in this procedure, in this case, are the Oberlin procedure 1 and the intercostal transfer 2. The intercostal transfer involves using intercostal motor nerves and plugging them into the biceps branch of musculocutaneous, as you see here on the left panel. The right panel, I don't know if you can see it that well, but it just shows it just highlights the fascicles that are obtained from the ulnar nerve in the Oberlin transfer and how they're attached, how they're co-opted to the biceps branch of the musculocutaneous nerve. The other options for upper trunk repair techniques include, as we did in this case, spinal accessory to suprascapular nerve transfer. And this is to restore movement at the shoulder abduction. The picture, as you see here, shows, again, shows the transfer that's complete here. And as you can see here, the main important things to identify from our perspective, are really familiarity with identifying the accessory nerve in the posterior cervical triangle, and then exposing the brachial plexus supraclavicularly, as you can see done here on the right panel. Other main technique that, like I said, we did in this procedure is the partial radial to axillary transfer. And this involves identifying the axillary nerve, as we did in the quadrilateral space here. So that's this space right here, and identifying the radial nerve in the triangular space, and performing a transfer, as Dr. Murray had alluded to previously. It's basically what I have. If anybody had any questions.
A great presentation, Krishna. Thank you, and thanks, Dr. Murray, for being here with us as well. It's always nice. I remember, like when I was in training in Brazil, we had one of the facilities had a very nice volume of peripheral nerve, and the nice thing, the anatomy of peripheral nerve surgery is actually also pretty interesting. So it kind of matches well. Like for you, Krishna, who has interest in vascular, it's nice to practice the the anastomosis as well. It's a good exercise too.
Just one point I wanted to make. A very nice job, Krishna, and thank you for that overview. When it comes to the Oberlin transfer, we get very, very specific about what fascicles, and it's quite amazing. The ulnar nerve has tremendous redundancy in the upper arm, but we can map out the posterior medial 2 fascicles of the ulnar nerve are generally supplying the FCU. So we can use a handheld disposable nerve stimulator, just like we do for the radial nerve, and map out those 2 fascicles that actually go to the FCU. And we isolate those 2 specific fascicles to tie into the biceps branch of the muscocutaneous nerve. Susan McKinnon and the WashU group have described a double fascicular transfer, where they take, in some situations, the fascicles to the FCR tendon from the median nerve, and supply the brachialis branch of the muscocutaneous nerve. So remember, the muscocutaneous nerve has 3 branches in the upper arm: the biceps branch, the brachialis branch, and then it continues on as the lateral antebrachiocutaneous nerve. So we can isolate those 2 individual nerves and do a double fascicular transfer to the biceps, which has been popularized at WashU. There's a paper out of Mayo Clinic Rochester that doesn't show any significant improvement in strength with the double to the single fascicle transfer, but it is an option. So the interesting thing is that almost never do you see any morbidity from an intraneural dissection of the ulnar nerve in the upper arm for this procedure, which is really quite remarkable. And you don't see any diminution of FCU's strength after taking those 2 fascicles, again, speaking to the tremendous redundancy of the ulnar nerve in the upper arm.
Very good. Thank you, Dr. Murray. Appreciate the comments, and thanks for joining us today.
You bet. Thank you.
Dr. Chaichana, team, any final comments as well about this case? No.
Very good presentation, Krishna. And obviously, it's outside of your comfort zone and our residents' comfort zone. So really commend